Hi, this is Dr. Akhtar Amin and today's chapter is scleritis and episcleritis. So first of all, episcleritis, it is a common and usually idiopathic, benign, recurrent condition. It is frequently bilateral. The females may be affected more commonly than males, except possibly in children and whom episcleritis is rare. The average patient is middle-aged. It is typically self-limiting, tends to last from few days up to 3 weeks, but rarely longer. The associated disease either ocular like dry eyes, rosacea, contact lens wear, systemic diseases, collagen vascular disease like rheumatoid arthritis, herpes zoster ophthalmicus, gout, Crohn's disease. Others has been identified in tertiary referral centers. Infectious causes are very rare, but a wide range has been reported, and investigations of recurrent cases is as for scleritis. So the acute episcleritis is common, usually idiopathic, has a good visual prognosis. First, simple episcleritis. It accounts for 75% of cases. It tends to recur 60%, decreasing in frequency with time. Features upon peak within 24 hours, gradually fading over the next few days. Symptoms: discomfort ranges from absent up to 50% to moderate symptoms. Giddiness is common. Photophobia may occur. The signs: more than half of cases are simultaneously bilateral. The visual acuity is normal. Redness may be sectoral in 2/3 cases and diffuse in 1/3 cases. Often it has an interpalpebral distribution in triangular configuration with the base at the limbus. Chemosis, ocular hypertension, anterior uveitis, keratitis are all rare. So, treatment: if mild, no treatment. Cool compresses, refrigerated artificial tears may be helpful. A weak steroid 4 times daily, and occasionally more intensive instillation, and occasionally more potent preparation with rapid tapering. NSAID as alternative. Oral NSAID is required occasionally. Occasionally a more potent agent such as indomethacin. And it is very rare for more aggressive systemic treatment to be required, and this is typically in patients with a known systemic association. Next is nodular episcleritis. It affects females more than males. Less acute onset, more prolonged course. In this nodular, there is red eye, first noted on waking, and over the next 2 to 3 days, redness enlarge and become more uncomfortable. Attacks usually clear without treatment and tend to last longer than simple episcleritis. There is a tender and red and vascular nodule, almost always in interpalpebral fissure, and more than one focus occasionally may be present. A slit lamp section shows an underlying flat anterior scleral surface. The scleral surface is flat. It indicates the absence of scleritis. Intraocular pressure is occasionally elevated. Anterior chamber reaction may be present but is uncommon. After several episodes, inflamed vessels may become permanently dilated. It is important to exclude other causes of nodule such as plectinulosis. A plectin is within rather than beneath the conjunctiva. So a plectin is within the conjunctiva, and conjunctival granuloma should be excluded. Treatment is similar to that of simple episcleritis. Next is immune mediated scleritis. Scleritis is an uncommon condition characterized by edema and cellular infiltration of the entire thickness of the sclera. Immune mediated non-infectious scleritis is the most common type and is frequently associated with underlying systemic inflammatory condition, of which it may be the first manifestation. Scleritis is much less common than episcleritis and comprises a spectrum from trivial and self-limiting disease to a necrotizing process, and that can involve adjacent tissues and threaten the vision. Recurrences tend to be of the same type, though 10% progresses to more aggressive disease. Classification of immune mediated scleritis. Classification of non-infectious scleritis. It is divided into an anterior and posterior type. The anterior is further divided into non-necrotizing and necrotizing type. The non-necrotizing is further divided into diffuse and nodular, while the necrotizing type is divided into vaso-occlusive type, granulomatous, surgically induced, scleromalacia perforans, and it is also known as necrotizing without inflammation. So first one type is anterior non-necrotizing, which is divided into diffuse and nodular. The diffuse type, it is slightly more common in females and usually presents in the 5th decade. Symptoms there are ocular redness, progressing a few days later to pain that may radiate to the face and temple. So the discomfort typically wakes the patient in the early hours of the morning, improves later in the day, and responds poorly to common analgesics. The vision may be blurred. Signs of the diffuse type. Here is vascular congestion and dilatation associated with edema. If treatment is started early, the disease can be completely inhibited. The redness may be generalized or localized to one quadrant. If confined to the area under the upper eyelid, the diagnosis may be missed. Secondary features include chemosis, eyelid swelling, anterior uveitis, raised IOP. As the edema resolves, the affected area often takes on a slightly grey-blue appearance because of increased scleral translucency. And this is due to rearrangement of scleral fibers rather than a decrease in scleral thickness. Recurrences at the same location are common unless an underlying cause is treated. The average duration of disease is around 6 years, and with the frequency of recurrences decrease after the first 18 months, the long-term visual prognosis is good. So the long-term visual prognosis is good. The next type of anterior non-necrotizing scleritis is nodular type. The incidence of nodular and diffuse anterior scleritis is the same, but a disproportionately large number of those with nodular disease have had a previous attack of herpes zoster ophthalmicus. The age of onset is similar to that of diffuse scleritis. Symptoms: the insidious onset of pain followed by increasing redness, tenderness of the globe and the appearance of a scleral nodule. The vision is often reduced. Signs: scleral nodules may be single or multiple and most frequently develop in the interpalpebral region close to the limbus. Here you can see they have a deeper blue-red color than episcleral nodule and they are immobile. In contrast to episcleritis, a slit-lamp beam shows an elevated anterior scleral surface elevation. Multiple nodule may expand and coalesce if treatment is delayed. Installation of 10% phenylephrine drops will constrict the conjunctival and superficial episcleral vasculature but not the deep plexus overlying the nodule. As the inflammation in the nodule subsides, increased translucency of the sclera becomes apparent. The duration of the disease is similar to diffuse scleritis. More than 10% of patients with nodular scleritis develop necrotizing disease. But if treatment is instituted early, superficial necrosis does not occur and the nodule heals from the center, leaving a small atrophic scar. The next type is anterior necrotizing scleritis with inflammation. So we discussed non-necrotizing type. Now we will discuss anterior necrotizing type with inflammation. Necrotizing disease is the aggressive form of scleritis. The age of onset is later than that of necrotizing scleritis. Age of onset is later than that of non-necrotizing scleritis, averaging 60 years. The condition is bilateral in 60% of patients, and unless appropriately treated, especially in its early stages, may result in severe visual morbidity and even loss of the eye. So, necrotizing scleritis is a serious and aggressive form of scleritis that requires systemic immunotherapy to control inflammation and preserve vision. Clinical features: symptoms: there is gradual onset of pain that becomes severe and persistent and radiate to the temple, brow, or jaw. It frequently interferes with sleep and respond poorly to analgesia. The signs vary according to the following three types of necrotizing disease. The first type is vaso-occlusive, commonly associated with rheumatoid arthritis. Isolated patches of scleral edema with overlying non-perfuse episclera and conjunctiva are seen. The patches coalesce and, if unchecked, rapidly proceed to scleral necrosis. There is granuloma formation in conjunction with conditions such as granulomatosis with polyangiitis. Granulomatosis with polyangiitis or polyarthritis nodosa. The disease typically starts with injection adjacent to the limbus, then extend posteriorly. Within 24 hours, the sclera, episclera, conjunctiva, adjacent cornea become irregularly raised and edematous. Surgically induced scleritis typically starts within 3 weeks of a procedure, though much longer intervals have been reported. It may be induced by any type of surgery including strabismus repair, trabeculectomy with excessive exposure to mitomycin C, excision of pterygium, and scleral buckling. A necrotizing process starts at the site of surgery and extend outwards but tend to remain localized to one sector. Now the investigations. Laboratory investigations should be employed as adjunct to clinical assessment, and evaluation by a general physician or rheumatologist should be considered. Specific tests may include erythrocyte sedimentation rate, C-reactive protein, full blood count, for example, anemia related to inflammatory connective tissue disease, eosinophilia for polyarthritis nodosa, atopy or Churg-Strauss syndrome, rheumatoid factor anti-nuclear antibodies, also known as ANA, anti-neutrophil cytoplasmic antibodies, ANCA, and anti-cyclic citrullinated peptide CCP antibodies. Serum uric acid, syphilis serology, Lyme serology, hepatitis B surface antigen for polyarthritis nodosa, and anti-phospholipid antibodies. Investigations for tuberculosis, sarcoidosis, ankylosing spondylitis may be appropriate. So these are a large number of investigations which should be done in case of scleritis. Radiological imaging, chest, sinus, joint, other imaging may be indicated in investigation of a range of conditions such as tuberculosis, sarcoidosis, Churg-Strauss syndrome, vaginal granulomatosis, ankylosing spondylitis, and other conditions. Angiography. Fluorescein angiography of the anterior segment helps to distinguish necrotizing disease by the presence of non-perfusion and can be used for monitoring. So, fluorescein angiography of the anterior segment, it distinguishes necrotizing disease by the presence of non-perfusion. Occlusion is predominantly venular in inflammatory disease and mainly arteriolar in scleromalacia perforans, which we will discuss. Endocyanine green is more accurate indicator of disease activity. Ultrasonography can help to detect associated posterior scleritis, which we will discuss. And biopsy may be considered in resistant cases, especially if infection is suspected. Complications of anterior scleritis. Acute infiltrative stromal keratitis may be localized or diffuse. Sclerosing keratitis characterized by chronic thinning and opacification in which the peripheral cornea adjacent to the site of scleritis resembles sclera. Peripheral ulcerative keratitis is characterized by progressive melting and ulcer and may constitute severe risk to the integrity of the eye. In granulomatous scleritis, the destruction extends directly from the sclera into the limbus and cornea. This characteristic pattern is seen in granulomatosis with polyangiitis. Polyarthritis nodosa, relapsing polychondritis. Peripheral corneal ulcer can occur at any age of a necrotizing scleritis and in rare cases precedes its onset. Uveitis, if severe, may denote aggressive scleritis. Glaucoma is the most common cause of eventual loss of vision. The intraocular pressure can be very difficult to control in the presence of active scleritis. Hypotony, rarely phthisis, may be the result of ciliary body detachment, inflammatory damage, ischemia. Perforation of the sclera as a result of inflammatory process alone is extremely rare. Scleromalacia perforans. Consists of 5% of the scleritis, and it is a specific type of progressive scleral thinning. Without inflammation, that typically affects elderly women with long-standing rheumatoid arthritis, but has also been described in association with other systemic disorders. Despite the nomenclature, perforation of the globe is rare as integrity is maintained by a thin layer of fibrous tissue. Differential diagnosis is from the innocuous scleral hyaline plaque and senile scleromalacia. The symptoms are mild, non-specific irritation, pain is absent, vision is unaffected, and keratoconjunctivitis sicca may be suspected. Signs: there is necrotic scleral plaques near the limbus without vascular congestion. Coalescence and enlargement of the necrotic areas and a slow progression of scleral thinning with exposure of underlying uvea. So, the treatment is effective in early disease, less useful in advanced disease. No consistent benefit from any specific agent has been demonstrated. Frequent lubricant installation, local or systemic anticoagulant agents, immunosuppressives including topical or oral, but not periocular injection of steroids and topical cyclosporine. So, and biological blockers have been used. Underlying systemic disease should be treated. Protection from trauma is important. Surgical repair of scleral perforation, for example, patch grafting may be required to prevent thysis bulbi. Lastly, the topic is posterior scleritis. It is potential blinding condition in which diagnosis is commonly delayed with an adverse prognostic effect. And the inflammatory changes in the posterior and anterior scleral disease are identical and can arise in both segments simultaneously or separately. The age of onset is often less than 40 years. Young patients are usually otherwise healthy, but about a third over the age of 55 have systemic disease. Diagnosis: symptoms: pain does not correlate well with the severity of inflammation, but tends to be more severe in those with accompanying orbital myositis. Photophobia is not dominant feature. Signs: the disease is bilateral in 35% cases. Choroidal folds are usually confined to the posterior pole and oriented horizontally. These are the choroidal folds. Exudative retinal detachment occur in around 25%, and the yellowish brown subretinal exudative material can be mistaken for a choroidal tumor. Uveal effusion with choroidal detachment may be present. So the exudative retinal detachment, which occur in around 25% cases, it can be mistaken for a choroidal tumor. Disc edema with accompanying reduction of vision is common and is caused by spread of inflammation into the orbital tissue and optic nerve. Treatment must not be delayed in these patients as permanent visual loss can rapidly ensue. Myositis is common and gives rise to diplopia. And pain on eye movement, tenderness to touch, and redness around a muscle insertion. Proptosis is usually mild and is frequently associated with ptosis. Occasional features include raised IV, periorbital edema, chemosis. Associated anterior scleritis is a useful diagnostic aid but occurs only in minority. Ultrasonography may show increased scleral thickness, which you can see here, and scleral nodules. It can show and separation of tenon capsule from the sclera, disc edema, choroidal folds, retinal detachment, fluid in the tenon space may give a characteristic T sign. Here you can see fluid in the tenon space, the stem of the T being formed by the optic nerve, and the crossbar by the fluid containing gap. MR and CT may show scleral thickening and proptosis. There is scleral thickness and proptosis. Differential diagnosis is of subretinal mass, Alternative lesions include miscellaneous granulomatous condition, choroidal neoplasia, choroidal folds, retinal stria, disc edema. Also occur in orbital tumors, orbital inflammatory disease, thyroid eye disease, papilledema, and hypotony. Exudative retinal detachment in what Koyanagi-Harada syndrome and central serous retinopathy. Orbital cellulitis may cause proptosis and periocular edema but is associated with marked pyrexia. Important systemic associations of scleritis. The first one is rheumatoid arthritis, the most common, and there is polyarthropathy, extra-articular manifestations. In the third decade is giant swelling, especially hands, more common in females. Rheumatoid factor autoantibodies in 80 to 90% patients. All forms of immune-mediated scleritis have been described in rheumatoid arthritis, and the clinical course is often more aggressive than when there is no systemic association. Other ocular manifestations of rheumatoid arthritis are keratoconjunctivitis sicca, also known as secondary Sjogren syndrome, ulcerative keratitis, and acquired superior oblique tendon sheath syndrome, which is very, very rare. So the most common is rheumatoid arthritis in any scleral inflammation. Granulomatosis with polyangiitis or vaginal granulomatosis. Idiopathic multisystem disorder. Small vessel vasculitis, primarily the paranasal sinuses, lower respiratory tract, kidneys and skin. And male predominance, fifth decade on the average. Pulmonary symptoms, C. ANCA in 90% patients. With active disease, scleritis is rapidly progressive, necrotizing, granulomatous. Other manifestations, there is peripheral ulcerative keratitis, occlusive retinal vasculitis, orbital inflammatory disease, nasolacrimal obstruction, dacrocystitis, rarely tarsal conjunctival disease. Relapsing polychondritis, rare. Small vessel vasculitis, involve cartilage, recurrent, progressive. Multiple organs involving the ears, nasal cartilage, respiratory system, heart, joints, middle age. Scleritis is intractable, maybe necrotizing, non-necrotizing. Polyarthritis nodosa, idiopathic aneurysmal vasculitis, medium size and small arteries. There is multiple organ involvement, third to sixth decade, male to female ratio 3:1. Ocular involvement may precede the systemic manifestation by several years. 1/3 have hepatitis B infection. Scleritis is aggressive, necrotizing. Peripheral ulcerative keratitis, orbital serotumor, occlusive retinal periarthritis. Crohn's disease, chronic relapsing bowel disease, unknown cause, peripheral arthritis, erythema nodosum. Eye is involved in 4 to 10% patients. Acute episcleritis, acute anterior uveitis, marginal keratitis are common. Conjunctivitis, optic neuritis, orbital inflammatory disease, retinal vasculitis have been reported. And acute anterior scleritis is rare. Complications of scleromalacia perforans, acute episcleritis and bowel activity show close correlation. Last one is treatment of immune-mediated scleritis. Topical steroids do not affect the natural history of the scleral inflammation, may relieve symptoms and edema in non-necrotizing disease. Systemic NSAIDs should be used on their own only in non-necrotizing disease. Often necessary to try a number of different drugs. So, cyclooxygenase inhibitor may be prepared in elderly patients, COX-2, if there is history of peptic ulcer, but there is cardiovascular side effects and GAT hemorrhage. Periocular steroid injection in non-necrotizing disease. Systemic steroids, prednisolone, when NSAIDs are inappropriate or when there is necrotizing disease. Intravenous methylprednisolone may be used initially. Immunosuppressives, immunomodulatory therapy. If there is if the control is incomplete with steroids, if they can be added as a steroid sparing measure in long-term treatment or to treat underlying systemic disease like granulomatosis with polyangiitis, polyarthritis nodosa, RA, relapsing polychondritis. So there is immediate treatment with immunomodulatory agents. The drugs are cytostatics like cyclophosphamide, azathioprine, methotrexate. Drugs acting on immunophilins like cyclosporine, tacrolimus, and biologicals. In necrotizing disease, rituximab is particularly effective in the treatment of necrotizing scleritis. Thank you so much.